and this is the third most common injury found in all runners, and it's the most common injury outside of the knee. It's plantar fasciitis. As you can see, the term for it is still the itis, something I'm working on. We'll see if we can change that in literature anytime soon. But plantar fasciitis, has anyone here ever had plantar fasciitis? It is super common. None of you have had that? Exactly. Impressive. So the plantar fascia, if you look at the photo on the right, it is the entire dense tissue that runs from the base of your heel all the way up to your toes, okay? Where that number 1 is close to the most common area that if you have plantar fasciitis that you're gonna experience your pain. But if you move over to this photo, can you see the red spot like right near the heel? So the pain that you're gonna get is right through this area. So most individuals that have this will come to me, I ask them where their pain's at, and they very quickly just go, boom, it's right here, all right? That's right where that plantar fascia inserts. It's a super thick tissue on the bottom of your foot. Even though it's thick, powerful, and strong, very susceptible to injury. The presentation with this is it's actually most painful at the first few steps in the morning. Outside of the morning, if you've been sitting down for a while, whether it's work, your house, reading, whatever you're doing, it can still become painful. So really, anytime your foot has allowed to get cold and tighten up, those first few steps become very painful. People describe this as like a knife stabbing into their foot. It's not comfortable. Usually feels better after a few minutes of running and then painful again after resting, and it might even be increased or have increased pain when you're walking barefoot. The risk factors for plantar fasciitis is a tight gastroc-soleus complex. That's just the fancy term for tightness in your calves. If you have tightness in here, it'll increase the pull on the Achilles that can change the force through the plantar fascia. So this is why finding out the true cause of your pain matters. And very importantly with plantar fasciitis and even Achilles tendinopathy, if you have decreased ankle dorsiflexion mobility, that's a very high risk factor. That dorsiflexion mobility is, again, this motion. And what that looks like functionally is anything that requires this. So if you're running, going downstairs, anything like that, and you don't have this capability, it's going to change the force in your Achilles and the plantar fascia. Very interestingly with this is if you have 0 degrees of dorsiflexion, there's a 23 times increase in the risk of developing plantar fasciitis. That's one of the first things I look at if someone comes in with me with plantar fasciitis is what's their dorsiflexion range of motion. Because if it's at a 0 and you don't even have pain there yet, we need to fix that. And then decreased subtalar mobility. That's just another joint in the foot. The heel, there's a joint here where that plantar fascia inserts. If you have decreased mobility in that joint, again, it increases the forces through that plantar fascia, but it's something we can address, treat, and stabilize it with orthotics or taping if we need. Standard approach that I see with this is placed in a walking boot. There are times where it's literally the only thing you can do because it becomes so painful and debilitating that if you're not in a boot, you're walking like this, okay? So if that happens, fair enough. 9 times out of 10 though, they don't need to be in a walking boot. It's just painful, so the doc throws them in a boot and then tells them to wait 6 weeks. Advice to go on complete rest, possibly have injections. Same thing we've been talking about quite a bit. When individuals are advised to rest, most people hear that as complete rest. Most physicians or healthcare provider, that's not what they mean though. They just mean relative rest, okay? So if you're told to rest, we have to figure out what you can do because totally resting it makes it worse. Injections, same thing, weakens the tissue. Last case resort, you definitely don't want to go down the route with this of just getting tons and tons of injections because the likelihood of having your second injection dramatically increases by having the first one. Recalibrate, we have to treat the surrounding joint dysfunction. Do you have a limitation in ankle mobility, calf mobility, biomechanics up the chain? What's going on? We have to figure that out, treat that accordingly. And then with this, I can apply an arch support tape to determine if orthotics are necessary. There's a specific way to tape it, and if that improves your symptoms by 50% or more immediately and within 2 or 3 days, then the chances of me prescribing you an orthotic over the counter of that being helpful goes way up. So if I'm going to encourage someone to go buy something off the shelf, I like to make sure that it has a high chance of helping. This is one way to do it. Mobilize the foot and the ankle stiffness as needed. And as always with all these diagnoses, educate on proper exercise modifications for faster recovery. Full bed rest, not the answer. What can you do? And then we go from there.